Very good. So as is tradition, the start, oh, thanks Lena for raising your hand there. I know others of you can't raise your hand, but you're starting off. Academic year, new academic years are always a fresh start. It's great to meet new folks. And congrats to all of you for making it through most of July when you're new to something. I'm Kate Bennett. I am the medical director for Project ECHO-Geriatrics, and I'm going to spend this session introducing all of you to the ECHO model and age-friendly care. And we'll run this session like we usually do, which is by starting off with a brief didactic. Today will be this introduction to those two topics, and then we'll have a case discussion of a complex case that we'll discuss with an interprofessional panel. Interprofessional teamwork is so important to the care of older adults, and so that's at the heart of what we do with ECHO. So let me just get started and tell you a little bit about what we're doing, and if you haven't already, please do introduce yourself in the chat if you can. All right, so what I'm going to go over is the context of Project ECHO-Geriatrics. What is ECHO? Why am I saying that word over and over? I'll then describe age-friendly healthcare and that model of care. And then I'll review a little bit about the nuts and bolts of ECHO participation so you're ready for the year. Okay, so the ECHO model is not something I made up. It was created by a physician by the name of Sanjeev Arora. Dr. Arora is a hepatologist and is expert in the care of hepatitis C. And a couple decades ago, he found that in New Mexico, he had many patients who needed to be seen for specialty care with hepatitis C, 30,000 patients who need to be seen, but very long waits to get into the only academic medical center in New Mexico, with a lot of patients getting very sick before they could be seen or not being able to travel, which set up some great disparities in care, some awful disparities in care. And his approach to that was, what if we trained primary care providers to provide the specialty care right where the patients live, so that they can receive their hepatitis C care from someone they know and trust and is local. And so he set up this Extension for Community Health Outcomes model, or ECHO model, which is a session similar to what you're on right now. And he ran a series of sessions for primary care providers with a didactic about hepatitis C. And then the heart of it, the majority of the time was spent in case discussions. And over time, these primary care providers got really good at treating hepatitis C. And he looked at it systematically and published an article that was in the New England Journal showing that the outcomes for patients who went all the way to the academic medical center to have their hepatitis C treatment by the academic physicians was similar to that being provided by the primary care providers. In fact, in some ways, it was much better, and a wider range of patients were able to be served by the ECHO model. So this model really took off as a great paradigm for how we can train primary care providers to provide some aspects of specialty care. And it's been used for a lot of different topic areas. It started off just at New Mexico, spread to the University of Washington and a lot of other sites, and has been spread throughout the world. And you can see these are all places now with ECHO programs. And it's been utilized for many specialties: infectious disease, such as HIV and hepatitis C, but also behavioral health and substance use disorders, and geriatrics as part of that. So why did we launch Project ECHO-Geriatrics back in 2016? Well, this is not new information for any of you, but just to highlight, the number of older adults in our country and in the world is increasing. And a particularly rapid rise in those who are 85 and older. But the number of geriatricians and geriatric specialists in a variety of health professions is not keeping pace with that. Now, you can just see by way of comparison, there are a little under 7,500 geriatricians in the United States, compared to 33,000 cardiologists, 112,000 pediatricians. So we couldn't possibly have geriatricians take care of all of the older adults. And we know that all primary care team members care for older adults, but there's a special skill set in the care of older adults because of age-related changes and conditions more common with older adults, and some of the supports needed to help people age successfully in place. And so the idea is that if everyone is trained in geriatrics, that we can all work together to improve the care of older adults. So we launched Project ECHO-Geriatrics in January of 2016 as part of our Northwest Geriatrics Workforce Enhancement Center, which is a federally funded center. There are 46 of them across the United States. Not all of them have ECHOs, but they all focus on improving primary care geriatrics. We run these sessions year-round, once a month for 1 hour, and every time there's a mini didactic, and all of those are recorded and on our website. You can always review those later. We have some time for discussion after the didactic, but the heart of ECHO is always the case discussion, challenging cases of older adults that are presented by one of you. And today, Dr. Rubenstein has been kind enough to offer to present a case, but each month we'll ask for someone to present a case and submit that in advance. And we can talk about it all together and with our interprofessional team. So why focus on geriatrics? Lots of people care for older adults. So how good of a job are we doing? We generally, as a nation, are not doing great in the quality of care for older adults. For example, over 30% of older adults are prescribed potentially inappropriate medications every year. These are medications that might contribute to falls or cognitive impairment. Falls result in over 2.8 million injuries that are treated in emergency rooms every year and lead to over 800,000 hospitalizations. And this is despite the fact that falls are largely preventable through evidence-based strategies. Only about half of those with dementia are diagnosed with it. So people have dementia, but it's never diagnosed or not put in their chart. And that makes it impossible to provide evidence-based care for dementia or do things like advanced care planning. And this isn't because older adults aren't spending time interacting with the healthcare system. The average older adult spends 17 contact days per year engaged in healthcare, meaning clinic visits, therapy visits with a physical therapist, or lab testing or procedures, hospitalizations. So the average older adult in this country spends 17 days out of their year doing that. So it's not the quantity of the care, it's the content and the quality of the care that folks are receiving. And so because the number of older adults is rising so rapidly and we need to do something now to improve care, several groups got together and said, we need to change this quickly. So the Institute for Healthcare Improvement and the John A. Hartford Foundation, along with some other groups, got together and said, let's change this. Let's look at the evidence and see how we can change the care of older adults throughout the country more rapidly. So they developed this idea of age-friendly care. What is age-friendly care? It is care that follows an essential set of evidence-based practices, or the 4 M's, and I'll talk about what those are and how they were developed. It causes no harm. And most importantly, it aligns with what matters to the older adult and their family caregivers. So really focusing on what's most important to the individual in front of you. The 4 M's of age-friendly health systems are what matters, medication, mentation, and mobility. The process of rolling out age-friendly care as a paradigm, thinking about these 4 M's for all older adults, really helps close this no-do gap. We have a lot of evidence for things that can help improve the care of older adults, reduce unsafe prescribing, and reduce the risk of delirium, reduce falls. But a lot of them are not reaching the point of care and reaching the older adults that can benefit from them. So the idea is to close this gap. So the way they developed the 4 M's of age-friendly care is they looked at models of care that we know improve the care of older adults. A group of experts got together from IHI and John H. Hartford Foundation. They put together a panel of experts to review the literature and just see what do we know that is really helpful in improving the lives of older adults and improving outcomes. And they were able to look at these models of care and see what overlaps. And they found 90 care features. They found similar concepts that they can distill into 13 care features. And then they were very clever and realized that we wouldn't remember the 13 M's of age-friendly care. And they distilled it down to the essential those 4 M's of age-friendly care. So they're based in the evidence. And again, they're what matters: medication, mentation, and mobility. And I encourage all of you, and I'm going to explain what each of these mean in a little bit more detail, but I encourage all of you to think about all 4 of these M's anytime you care for an older adult. It's really changed the way I think through things and teach care of older adults. It's easy to remember, and it really hits on some of the most important things that we might otherwise miss. So the what matters M is knowing and aligning care with an older adult's health outcome goals and care preferences, including but not limited to end-of-life care and across settings of care. Meaning this includes advanced care planning, making sure someone has a surrogate decision maker and a living will, and in places that use a post form, but also thinking about what matters now. And really aligning care with what's most important to someone. Is it that they want to be able to spend time with their family? Is it that they want to be able to go do their volunteer job and their mobility is preventing them from doing that? So really aligning what you're doing with what's most important to the person in front of you, and asking them is the only way to find that out. Medications. Thinking about if a medication is necessary, using age-friendly medications that do not interfere with these other M's, like what matters, mobility, and mentation, and doing that across all settings of care. Mentation focuses on preventing, identifying, treating, and managing dementia, depression, and delirium across settings of care. And mobility is ensuring that older adults move safely every day to maintain function and do what matters. So this includes fall prevention, but it also includes finding ways to optimize someone's ability to do their activities of daily living. So there are some key points to these 4 M's as you're thinking about it with all of the older adults that you're caring for. These 4 M's are a framework, and they're meant to be implemented together and reliably, meaning you don't just do 1 M for this patient and another M for that patient. It's that all 4 M's really work together to help someone live as well as possible. And reliably, meaning that every older adult that you care for receives this care. That's the best practice. It doesn't mean that you can address all of the M's in one visit for every patient, but it does mean that having a plan for doing it overall for each older adult. They can be implemented across an entire health system. You can go big, and Dr. Rivenstein can tell you about her experience with implementing age-friendly care in her health system. But you can also do it as an individual practice or site or person. Really, this paradigm of age-friendly care is helpful however you roll it out. And it should be incorporated into what you already do. So look at what you already do and just add the things that are missing. It's not supposed to be like, I'm going to do primary care and then also this 4M thing. It really gets woven into what you do and the way you think about things. And the tools you use to implement it can vary. There's no one specific dementia screening tool you should use, or certain, list of medications, although there are some more commonly used. It's just that it should be evidence-based and fit with your setting so that it runs smoothly. There are 5 pioneering health systems that tried this out first, but it's been since disseminated to many, many, many sites. And I'll show you a map. These are all of the places throughout the country that, as of when I looked at it yesterday, have been officially recognized by the Institute for Healthcare Improvement to be age-friendly. And in order to get that recognition, you just have to submit a form that shows how you assess and act upon each of those 4 M's in your setting. And you can get that designation. And then there's a higher level designation you can get if you show that you do that consistently over time. So how to operationalize these at the point of care or in your clinic or in your hospital or skilled nursing facility is for each of the 4 M's, you need to both assess and act upon them. So it's not enough just to assess for fall risk if you don't act upon it and do something to do some fall prevention. And the same with cognitive assessment. If you're screening for cognitive impairment, if you don't have an action plan of what you're going to do with it afterward, it's not complete age-friendly care. There is an entire guide to using the 4 M's in the care of older adults in hospitals and ambulatory care practices on the IHI website. They have a ton of resources there, videos. There are action communities you can join to really dig into age-friendly care. But if you're just looking at ways to improve the care that you're providing to older adults, there are just some great resources to look at. All right, I am going to shift to talking a little bit about ECHO and what to expect, and then we'll have some time for questions and discussion. So the Project ECHO-Geriatrics panel is interprofessional, but I consider everyone who participates in this to be part of the panel as we're discussing patients, and we learn a lot from each other. ECHO is an all teach, all learn model. So I learn things from you and we all learn things together. But there are folks from the Area Agency on Aging who really particularly know about community resources. There are clinical social workers and gerontological nurses, geriatricians, geriatric pharmacists, and geriatric psychiatrists who participate on our panel every month. The heart of ECHO, again, is case discussion. That's a lot of how we learn and how we think about age-friendly care principles and improving the care of older adults. And anyone can submit a case. We talk about at least 1 case each month, sometimes more than 1. And any of you can submit this. So most of the time they have a primary care focus, although we're open to other things. Anyone can present, absolutely anyone. It could be a student, a resident, a faculty member, someone in your practice. It could be anyone from your interprofessional team. We've had speech pathologists who present, and physical therapists and pharmacists. So anyone from the primary care team can present. It's okay to leave sections on our very long case form blank. It's meant as a tool just to help you think through some of the aspects of the case that might be helpful to discuss. It might be, but you can leave them blank because it's not meant to be a barrier to presenting. Please de-identify all the patient information that you submit before you submit it. That's very important. We ask that if you submit a case that you try to do it 48 hours in advance, although I will say that that's not a hard deadline, and if it isn't at 48 hours in advance, we could usually still take it. And we ask that for the residency sites participating, that each of you present at least 1 case sometime between July and June during this academic year. So we can see, we can hear from a lot of you. Amy Verrill is our most fantastic program coordinator, and she is the program coordinator not only for Geriatric Workforce Enhancement Center, but also for ECHO, and she will be sending emails with updates and has the case form. After each session, we send out a resource email that tells you about resources we discussed during the didactic and the case presentation so that you don't have to necessarily copy them down furiously and that you have them somewhere you can refer back to. Just a few last thoughts about optimizing your ECHO participation. If you have your video on, it's great, so we can build some community, get to know each other a little bit, but I also understand there are times where you are somewhere where you cannot put your camera on. And we've all learned about that over the last few years that we've used webinars, Teams so often. Invite your whole team to participate, especially if you're presenting a case, but anytime, all are welcome to Project ECHO. And the more disciplines we have represented in ECHO, the richer the learning, because again, geriatrics is something best practiced in an interprofessional team. And then again, this is an all teach, all learn model. So joining the case discussion, add your expertise, add suggestions during the cases. We all learn a lot from each other. So that is a summary of age-friendly care and Project ECHO. I'm happy to answer any questions. I know there's some in the chat, but I'm glad you are all joining us today. And I really think that together we will make healthcare more age-friendly. And learn a lot from each other. You can reach out to me anytime to discuss anything geriatrics related or ECHO related. My email is here, bennett4@uw.edu. And I'm looking forward to getting to know all of you better, and I'm glad to see many of you who have been on for a while. This is our evaluation survey that we have at the end of each of our sessions. I'll keep it up for a second. So that if you want to fill out an evaluation of this didactic, you can, but we'll do that every session, and the speakers do appreciate your feedback. All right, I'm going to stop there, and I saw that there are a few questions that came up during this. So it says that, Carrie mentioned that it's interesting to see the clustering of the map that's mostly on the eastern half of the United States. Yes, there are definitely more age-friendly sites clustered on the east, on the east side of the United States. And then Dr. Labardi was wondering if Indiana is incentivizing in some way. There are 2 geriatric workforce enhancement programs in Indiana, and those federally funded centers are also partnering to help disseminate age-friendly care in the model. And so it looks like they're doing a good job. So that's what I have. Any other questions or thoughts, or if any of you have experience with rolling out age-friendly care and want to share that, please feel free to unmute or type it into the chat. How many of you have experience with IHI's age-friendly care initiative and rolling that out in your clinical settings? You can raise your hand or type it in the chat. Kim, I know you worked on that during your time as a resident. Kim, did you want to share what you did with rolling out age-friendly care at your residency, if you don't mind?
Yeah, can you hear me okay?
Yes, it's a little bit quiet, but we can hear you.
Okay. So I got the form that you mentioned from the website for IHI. It was a very simple process, and a lot of primary care clinics already do a lot of what is encompassed on the worksheet anyway. And so what we really did was we were able to take it from getting that recognition for age-friendly for our clinic, which is a clinic that's associated with the community hospital across the street. And then really take it and sort of start to look at QI projects afterwards for the second component in level 2 recognition. I hope you can hear me okay. I'm sorry, I am traveling, which is why my camera is off.
We can hear you. It cut out a little bit, but we were able to hear what you had to say. So that's great that you were able to work on that as a QI project while you're a resident. And I know at our primary care clinic at Harborview and over at the VA, it was a geriatric medicine fellow who really spearheaded the process of getting age-friendly recognition there. And I know, Carrie, you have experience with age-friendly care.
Yeah, I'll be talking about case today and sort of trying to wrap in the 5 M's as well. But yeah, so we got when you join the action community and get your sort of I think they call it certification, right? Level 1 and level 2. You choose the setting with which you do that. And so the first time we did it in just our geriatric assessment clinic. And it was sort of ironic because we had already been doing all of that because it was a geriatric assessment clinic, but it really forced us to look at how we were reliably assessing and acting on the M's, and then it made the lens a little different. But yeah, I mean, I have a peppering of experiences in multiple different areas. Just like Kate, I am a fellowship program director in geriatrics, and I also teach in the family medicine faculty at Swedish First Hill. So we have designed all of our resident teaching now around age-friendly health system framework. We do a lot of our documentation in our inpatient consult notes using this framework. And so we think in this way a lot. And then I am part of Providence wide steering committee for age-friendly health systems. So Providence is a 50+ hospital organization, and the head of quality at Providence is really interested in age-friendly health. And because of that, is trying to figure out a way to, across a 50 hospital system, implement this. And you might imagine this is no small feat. But we are sort of taking small steps with an annual age-friendly symposium, which we just had not too long ago. We've had an within our organization action community. So that was cool. And that was one of the first times that IHI has had like an action community that's limited to one organization. And then we've had some opportunities for sort of scholarships for projects that were considered age-friendly. And people applied and we reviewed applications. And like, honestly, now trying to figure out next steps, because it's very, very hard to sort of implement this reliably in many different places. So it's been an interesting journey.
Great, thanks for sharing that. Did anyone else wanna share experiences? I would have to say that even it's wonderful and great and important to get the official IHI recognition eventually for your clinic or your health system or both, so that you can make sure you're being consistent with age-friendly care. But even if you can't, I'd say, it's pretty much every time I have a resident rotating with me in my primary care geriatrics clinic, we talk about the 4 M's and think about for each of the patients they're seeing. And it feels like it's a good way to wrap your head around something really complex, like to just really think about all of the realms that are most important for the care of older adults, and also patients, both like at the bedside that I've seen, like when I'm in the clinic room, people are really satisfied with care, but the literature also supports that older adults and their family caregivers are very appreciative of the focus on the 4 M's and the things that are most important to them. And also they bring a whole team to doing what's right for the patients and providing them the best care possible. So I think everyone wins with age-friendly care. It's not without its challenges, but I think it's a wonderful paradigm, and I'm glad that that's something that has evolved over the last 5 years or so. This was just rolled out in 2017, and so much has happened. Just look at all those places that have already adopted it. So it's pretty impressive. Okay, well, maybe we can shift to a discussion of a complex patient situation that Carrie had.